Having us on again for the second case. Congratulations on another exciting meeting. Social media has been lighting up like crazy. So thank you for being with us on this Saturday. Again, I want to welcome our team members here. We have Lisa and Abby, our nurses that are supporting us for this case. We have Nathan Sheridan, who is our lead tech at ACV Centers, and our interventional ultrasonographer and research coordinator, Abigail Mines. So we have a really good case for you. I'm hoping that it's going to generate a lot of discussion. Can I have my slides, please? So this is an out-of-area gentleman that was referred to us for originally rest pain of both lower extremities, Rutherford class 5 on the right. Typical risk factors. He does have a history of 2 bypass surgeries on the right side, one to the anterior tibial artery, one to the popliteal that we later discovered that actually was to the posterior tibial artery with, unfortunately, ligated posterior tibial artery. Recommended for an amputation on the right side and seeked another opinion with us. Underwent revascularization on the right side. He has a femoral popliteal, but I don't know if it's a popliteal. I think it's a fem-TPT bypass, and I'll be interested in the panel what they think. With monophasic flow in the bypass graft. Can I see the next slide, please? And this is diagnostic images from the left side when we treated the right side. And they're playing. You can see in the middle panel there. You see a perineal lesions, obviously, in the TPT-PT junction, and the outflow distally there. That's, again, an image from the left groin. I'm going to stop here. I just want to point out to PK that our patient is in what we call position number 1. So the right groin is available. The left leg is completely exposed, as you can see, to have access to our interventional ultrasonography. So I'll stop here, PK, and see what you guys would like us to do.
Yep. I mean, Fadi, you got a great panel. You got a great panel here, and I'm just going to turn to the panel and just ask Darren what his thoughts are about the angiogram and what his approach would be and what your thoughts are.
Yeah, it's a great case.
Can you guys show the ultrasound?
And there should be a lot of discussion about this. I think that I would also take an endovascular approach to this case, first of all. Patients already had bypass. It would be redo to do any surgery. It's like relatively focal lesions in those proximal tibials that you could go after, and so I would definitely do that. Now, I think the question is going to come in access and approach, and I generally don't primarily do pedal-only approaches for things, so I would start probably contralateral groin up and over, do my angiography, get down, do my intervention, but just like Fadi's done here, I'd have the leg prepped out and be prepared and ready to go retrograde tibial access.
Let's have a Navic cross, guys. Engel, oh, we have it.
Any thoughts from anybody else? Brian?
Yeah, I'd like the retrograde tibial approach here. In the event that you have issues, previous bypasses, fem bypasses for a prosthetic, you get a hematoma, it gets infected, it's an absolute nightmare. And so, it only takes that to happen a couple of times before you really start to rely on, kind of primary pedal access. So and it's funny, I actually learned a lot of my technique from Fadi and Jihad, and so I tend to mimic what they do from this standpoint. They really have, kind of revolutionized that kind of retrograde access and when it can be utilized in the correct way.
Sure. Karthik, any thoughts on how you would approach this?
Fadi, you know it's me, brother.
Oh, my God.
So I think primary pedal approach is reasonable here, but I would have probably gone just like Dr. Snyder said, up and above, done it from above, only because it looks like a femtip bypass graft. I just feel like, and the lesion is right at the TP trunk. So now if you are treating it, you have to treat the PT and probably go up and over, treat the peroneal also because the disease progresses into the peroneal. So you're ballooning across the TP trunk. Again, that's basically your anastomotic zone. So I would have probably done up and over, but again, approach is totally reasonable.
One last comment, Christian?
So putting those two things together, one, this is a threatened bypass. It's a bypass that is providing flow and perfusion to an area that needs more flow. So I will be rather interested in what is the outflow from the peroneal bypass thread lesion to the foot. So compromise and retrograde, something that I don't know. So I'd like to see that in order to go ahead and do a retrograde access. The other thing, as a surgeon, we can do a tiny cut down, access the graft, close that graft probably with a tiny little wound, like a varicose vein excision. So other options are there.
Yeah, that's what I was going to ask.
And avoid the groin, redo groin access, which I agree, I think we should stay away from.
Got it. So Fadi, you have a lot of good thoughts here. I mean, one of the questions is, what's the runoff distal into the foot? I guess that's what they wanted to really ask you.
Yeah, so, as you saw, the access was from the left groin. Mm-hmm. So I'm going to do an image here. As you know, PK, we depend heavily on our ultrasonography. So I don't know if you guys noticed or not, but the size of the posterior tibial artery distally was about 3.5 millimeters, which is, in my experience, a large size for distal posterior tibial artery that's underfilled. That's one thing. The other thing that we do with the TAMI technique, which is pedal-based revascularization, we use ultrasound-guided closure, meaning using the hockey stick probe to basically occlude our access site and allow patent hemostasis. So you can see that the medial and lateral plantar artery are open here. You can see the peroneal artery opening. There's clearly high-grade stenosis at the junction because I'm not able to fill it with retrograde injection. So we're going to go ahead and place a selective catheter up and take a picture. I have a V18 wire here. Mm-hmm. You can use also a Gladius 018 wire if you like 018 wires. You can also use the Command 018 wire. For these lesions.
So you do predominantly go with an 018 system in these lesions versus an 014?
No, I start with access with an 018 wire here. I'm going to take, this is a Navicross catheter, 035 Navicross catheter, and I'm going to take a selective image proximally. We already did EVAS mapping before the procedure, and I'm kind of holding some of the cards close by because I want to see what the panel wants to do. Look, mm-hmm. It's not filling, so between the time, which was maybe a week ago,
right,
until now, I don't know if it closed or not. So let me have a Xi'an black wire, please.
So what about the panel? What are the wires that you guys like to use in these kind of lesions? Shadi, what do you generally do in these kind of lesions in terms of?
There was antegrade flow though.
No, I always feel when you go in retrograde, you can be a little bit more aggressive because if God forbid you cause dissections, it's going to tack down, and even if you cause a perforation, the pressure is a little bit lower. So when I'm comfortable and I think I'm intraluminal from retrograde, I will quickly escalate. We're starting with a V18 platform.
3,000
a CTO, probably 014 wire.
Okay. Fadi, just one question to you. What's your anticoagulation when you come from below? I know you told us your cocktail stuff, but anticoagulation-wise, are you a heparin person or do you do something more exotic like bivalve?
No, actually, we nothing fancy. We use heparin. We shoot for an ACT between 220, 250. We don't go. I actually don't go above 250, even for tibial interventions. So, and we check ACTs obviously like everybody else.
Sure.
In our lab here. So I just switched to an 014 wire. Mm-hmm. And I'm using the Xi'an black wire. It's a good wire. It's a wire that I usually tell people like, okay, I can destroy it before I can do any damage if I'm concerned about the vessel. So, and here you go. It just went in very smoothly. Mm-hmm. But I want to point out that even with selective angiography, with the tip of the catheter next to what I think is a lesion, I was not able to opacify it. So I'm going to advance my Navicross catheter here into what appears to be a stented portion of a bypass. And we're going to take the wire up. Can I have the freedom flow wire, please? So this is my 014 wire. I'm going to go up all the way to the iliac system and start interrogating from above to below. So that's another question I get a lot, which is if you have retrograde access, are you able to see the anatomy with these patients? So this is how we usually do it.
I know you guys have pioneered this technique, and like for a lot of us, I know everybody's going pedal and coming up, but generally for just crossing and and externalizing the wire and working from above. So it's very interesting to see your approach on how you're doing this. And so the advantages.
Yeah, and we published a large case series in CCI, I believe, a year ago. No, actually, I'm sorry, 2 years ago. We had the comparison between traditional approach, TAMI approach, and the dual integrate and retrograde approach. So, and the results are pretty encouraging, and I know that the results have been repeated with other people. So if you guys notice that just my 035 catheter is occlusive.
Yeah.
Yeah.
So when you do EVIS, do you do EVIS at this stage to figure out the areas where you want to intervene, or how are you going to do it? Are you going to use the angiogram?
So before we started, the bypass graft and the vessel had the barely monophasic flow through it, and it looks like also there is high-grade stenosis within the stent itself. Mm-hmm. So all of these things, I'm already preparing in my head. What do I need to do for this patient? I already have IVUS open on the table that also we're gonna consider. And I'm gonna take a picture here. Again, the outflow is occluded, so we might not see much. We'll see. Yeah, so like I'm opacifying the graft, but because there's such high-grade stenosis, 90% stenosis. PK, let me ask you a question. I want to ask the panel. Let's say this patient was not symptomatic, and came to your office. Surgeons, cardiologist, any radiologist came to your office, and basically watch what's going to happen as I pull the navi beyond the stent, guys. Do you see how the contrast cleared? So that's where, based on EVIS, that's where the lesion was, and that's why you notice like I'm not hyperventilating, because I had the idea before we started. I knew that this is going to happen, and that's why I said I'm going to hold some information, because I want you to see. Oof. And here you go.
Yeah. Hey, that's a great question, Fadi. I'm going to throw it out to Christian. Christian, if this was an asymptomatic patient,
1.7 laser
with velocities increased at the threatened graft, I mean, talk to me about your algorithm on what you're going to do for this.
Exactly. I think the clear message to particularly the fellows and the early practitioners is we do not do asymptomatic interventions except maintenance of patency. So that's a primary patency intervention, because the graft is very threatened. It's a vein graft. Obviously, it's been intervened already, so it's a graft with, high risk in terms of patency, but, it's a second primary patency, and it should be intervened.
Yeah. Darren, a question to you as a surgeon. Excuse me, the cigar from last night. But
I wish I was there, but
I know.
There were cigars?
Yes, you do.
Join us. I don't know what you're talking about.
Take the fifth, right? But when I was training, we were always taught that, once a bypass graft is done, that before I intervene on it, because I'm going to change the natural history of that graft, if I put a stent in versus surgically repairing it, can you just expand on that a little bit? Because as an interventionalist, we're like, hey, I can go to the anastomosis, put a little stent in, and I'm done, versus you guys doing a surgical revision, maybe with a small cut down, as Christian said. Is that still hold true?
I think it's still something to consider in the algorithm. And I think when you think about it, like this was probably a distal anastomotic stenosis. You have to think about what the disease process is. It's not primary atherosclerotic.
PT.
So it's different. So it's more likely to be neointimal hyperplasia and a biologic process. So I think you have to think about that. If you put a bare metal stent into that and don't apply drug therapy or something like that, it's likely to fail. even with drug therapy,
TPT?
sometimes these can be recalcitrant and keep coming back. And I think in that case, in a young patient who has vein, you got to think that wouldn't be a hard jump graft just to jump
Popliteal?
from above this down to a nice tibial target.
Right.
That really wouldn't be difficult to do. But I initially would probably take a primary endovascular approach. I'm not sure I would be interested in laying a lot of
Bypass?
there necessarily.
Got it. So we're looking at your IVUS, Fadi.
Yeah, I want to point out that this appearance that you see around the graft, this is basically stagnant flow.
Yeah.
So it is not. All right, so let's do something a little bit to make us work in less stressful time frame. Let me have a 2.5 by 100 balloon, please. So I don't hesitate pre-dilating in these lesions. Especially if I have a lot of exchanges. I know, and I don't know if you can hear. Actually, I'll be curious what our physicians would like to do in this particular case here. What is the choice of therapy that they would like us to use?
So I'm just going to go around the panel, starting with Shadi. What's your choice of therapy? But let's look at the IVUS. Let's see the lesion morphology before they decide.
Common.
Yeah. As soon as you show us the IVUS of the lesion, I think they'll get a good idea of what they want to do.
External iliac.
Yeah.
Here you go. Let me show you the lesion.
Yeah.
It's in the stent. And right there.
Yep. Okay. All right, guys. Looks like a lot of intimal hyperplasia, as Darren described, maybe with some underlying thrombus. Shadi, what do you think?
I think you're seeing soft plaque here, so that's one thing to consider. The other one is you're seeing ISR. So I think that limits you to laser versus possibly jet stream or Rotarex.
Okay.
I'll probably choose one of those three.
Karthik, so you got three choices from Shadi. Karthik?
I would probably choose the same. I would either go with laser or Rotarex, and of course DC.
Let's have a 2.5 balloon.
Important. Looks like it's all just neointimal.
5.0 by 100.
Right.
Really, I don't see any calcification.
100.
Thrombus, I think, is
And a 3.5 by
questionable.
240.
I think there is some component of thrombus always in some instant restenosis, so I think it is definitely involved, but definitely mostly a restenotic tissue.
Darren, anything different?
No, I think that's a reasonable approach. I definitely would do DCB. This is like Tasaka 2 disease, so it's a patent stent with neointimal hyperplasia, and DCB has good results.
Would anybody do a primary thrombectomy here? Run anything through to prevent embolization? No, everybody feels no. Okay. Asma, what would you do? Anything different?
So what I would do is what everybody said, either laser, but I was actually thinking laser maybe with adjunct primary thrombectomy, just maybe if it's a set of 7, for instance, just run the Lightning 7 or just Rotarex.
Rotarex. Okay. So you got a bunch of choices here, Fadi. So why don't you tell us what you're going to do? And I'm going to go to our first lecture, and we'll keep you on the side, and we'll watch what you're doing.
Let's go up here. Yeah, so I think these are all great choices, reasonable choices. I usually would do thrombectomy if it's a CTO. This one is not a CTO, so and the presentation is not necessarily acute. So I don't think it's a wrong choice. I'm just saying, like, I don't feel very strongly about thrombectomy. But I'm going to use, because it's instant restenosis, I'm going to use Excite ISR data. So I'm going to use laser atherectomy followed by balloon angioplasty, and possibly drug-coated balloon angioplasty, like one of the panel suggested 10.
Fadi, we've been watching you along on the side as Dr. Fisher gave his wonderful IVUS talk. So can you just kind of go over what you've done, and then we can kind of talk about what your choice was?
Yeah, so we actually performed laser atherectomy using a 1.7 millimeter device. This is after 2.5 millimeter balloon within the ISR area there. I just didn't want to work in a static situation. So, and this is the 1.7. I usually will put it on maximum setting 60, 80, and especially if you have ISR, let it work there. One really refreshing thing here, this image here, I don't know if anybody can pick up on that. You guys see to the right of the screen, that's the anterior tibial artery.
Yep.
Hibernating there, but we did not see in any way, shape, or form. We saw it on extravascular ultrasound. There was flow through it, but that was really exciting. So this patient might have options. All the way probably if a stent, I'm not sure if a stent extends into the TPT or not. It looks like a flush occlusion there, but definitely an option for this patient in the future if we need to go back to this. So after laser atherectomy, in the posterior tibial artery also on the lowest settings. And this is an inflation with the 5.0 balloon. And I saved this image because it kind of gives you an idea that if this was thrombus at 3 or 4, at 2 atmospheres, I would have seen the balloon fully expanded. That's been my experience. I mean, not that we thought that this is a full thrombus or anything like that, but gives me a little bit more confidence that we're probably dealing with a hyperplastic tissue. Down, please. So I am down from inflation there. I'm going to take a picture to show you what we're going to do. Typically, I actually would treat the PT before, but I want to make sure that we're respectful of the time. So I don't know how much time, PK, we have.
Oh, you've got plenty of time.
I want to show you the final results.
Yeah, no, you've got plenty of time. I just want to ask the panel. I mean, there's so many choices of atherectomy devices and no head-to-head. So before I ask Fadi why you chose the laser, which I know that you guys talked about different devices. And Fadi, your sheet size in the posterior tibial is a 5.6 or a 4.5 or a 5.6 slender? I forgot what you put in the
I'm glad that you already went automatically to the slender sheets, right? So this is a cry for industry that we really need to develop a platform. Let's leave it on the wire, please, Nate. We need to develop a platform for tibial interventions. But I used a 4.5 slender sheet here. I know there's a huge movement toward R2P, which is great and definitely has a role for a lot of patients. But I think tibial interventions, is another space that we need platform to deliver. So I use a 4.5 here. 4.5, you can deliver stents, balloons, atherectomy devices, and DCBs. So this is an angiogram from the sheath.
Yep. Beautiful.
And
beautiful
again,
result.
really encouraging for the AT that I think if we go back retrograde, we can get that if we need to in the future. So this is not a true single vessel runoff. I just want to point out that to the audience and to the panel, right? You always get that question, would you do it if it's the last vessel? I mean, clearly here, this is not a single vessel runoff, as you can see, which is a good thing. We're going to go ahead and treat the posterior tibial artery next, but I want to answer. I'm going to be the first one to answer what you asked, BK. Why did I use laser? Mm-hmm. I mean, we have the only device that we have for in-stent restenosis trial, randomized trial, is the Excite ISR. Testing laser atherectomy for in-stent restenosis against balloon angioplasty and showed a favorable result. Like everybody else, I've used other devices off-label like Jetstream or directional atherectomy. They're not contraindicated, but they're definitely off-label use. So I'll be curious what other panel members want to use.
That's a great point. Any thoughts on the panel? Because I know how many of you would not have done an atherectomy, would have just gone to maybe a atherotomy, would say a serenator or chocolate and just put a DCB in or just direct DCB? So Dr. Schneider, go ahead, you first.
Let's go up here.
Certainly data with laser, in particular for in-stent restenosis. It's okay. It's not great. There's good data with DCB alone, especially for something that's not a Tosaka 3 like a long occlusion. And so I think it's reasonable to do some vessel prep and to treat with DCB alone for this hyperplastic lesion.
I think if I was using a 4.5 slender, I would have probably done an atherotomy and a DCB directly. Because I don't think a laser with 5 French would actually really do much for that vessel of that size.
Yep.
So if I was doing a 6 French or a 7 French, then it's a different story. But I think if it's 4.5, I would probably just do a cutting balloon in serenator, chocolate, and then just done.
Can you pull out the IVUS images, please, and show
So Fadi, I guess the question here, I think it's a valid question, is sizing of the laser. I mean, you went with a 1.7, right? I think you said, and obviously the vessel, at least the stent was, it looks like at least a 5 millimeter stent.
So can you guys put the IVUS image up?
PK.
Are you guys able to see the IVUS?
Yes.
So sorry guys. So I want to show you. This is the IVUS image. This is after the 2.5 millimeter balloon. The size of the catheter is 1 millimeter. So you have a 1.7 millimeter catheter used with maximum settings, creating a bubble. The one thing I did not do, I wish I did for you guys, is to show you under EVIS. So I'm not really sure why do we think that the 1.7 would not do much in this hyperplastic lesion here?
Fadi, I agree.
Right. So
yeah. Your Navicross was occlusive. So we know that even with a 1.7 and on the highest settings, you should, is it going to have the same effect as a 2 millimeter? No. But however, a 1.7 is going to modify that plaque and do some, it should do some, some modification, especially as you're closer to the.
Well, I agree with you because it is a form of vessel prep, but the question is, are we prepping enough? And I think Fadi's balloon angioplasty results showed that we were able to get enough of a lumen at the end. Until we do another IVUS to see what's going on. But Fadi, there's a lot of talk on IVUS, and I just want to bring this up to the panel. I know me and Dr. Tamala have talked offline about this. Without any hard data. We have no hard data. In coronaries, I can tell you, in left main, I can tell you over and over again, outcomes, really hard outcomes with IVUS. We don't have that. Are we just kind of spinning our wheels and kind of having a lot of opinions on what we see without outcomes? Don't we need to push Philips or other companies to say, hey, we need to do a trial to have some hard outcomes so that we can use your product? At least like you said, with Excite ISR, you have a randomized controlled trial showing efficacy of laser and eyes in in-stent restenosis. And I think that's what I want to just talk a little bit about, because we used to use a lot of IVUS. We've actually moved away from using IVUS because the point is that I don't find the value without having an outcome based on what I'm doing. Of course, when I don't know what I'm seeing, we use it. So what are your opinions? I know you Brian, and you Fadi, you guys use a lot of IVUS. How do you feel about that?
No, I think you raise a very fair point. Oh, sorry.
No, Fadi, please go ahead.
I think you raise a fair point. I think Brian and I feel strongly, but as you know, and you're a trialist yourself, lack of evidence does not mean lack of efficacy. And I know you don't disagree with that statement, but I agree actually with what you're saying. I think we need the larger trials to show the benefit and protect the field and show the importance of utilizing this technology in this space. Having said that, there are small trials. Cardiologists, I'm the first one to admit we're a bit spoiled. We're accustomed to these randomized large trials. So there's a paper that just came out of Australia. I'm sure Eric talked about, or probably Brian will talk about, showing the benefit. It was a small trial in 150 patients, showing that IVUS-based interventions had better outcomes for patients. We had a small trial retrospective looking at sizing of tibial vessels by angiography and IVUS, and it showed a significant difference between both arms with two blinded physicians. So I agree with you. I think that these trials are small enough, but they definitely give a signal toward an advantage or benefit. But I think a larger trial looking at the usage of IVUS across multiple beds also, right? So this IVUS might not make a difference in large iliac vessels where you use 8 millimeter versus 10 millimeter stent. But in my opinion, will make a big difference when you use it in 3.5 versus 2.5 millimeter vessels, like Brian and I say. So I don't disagree with your statement. Now, anecdotally, I think there's a big benefit, but having a larger trial will definitely be beneficial.
Everybody talks about the JACC Interventions paper that just came out, looking at how DCB outcomes were better with when IVUS was used. But when you go through the actual the table. They undersize the DCB in the IVUS arm, and how do you say that the outcome is because of the IVUS? It didn't make sense to me. So, it got published in JACC Interventions, a high impact journal, 2025, whatever it is. And unfortunately, it was something that did not make any sense to us when we did our journal club. So, I really feel that, we need a little bit more data before we hang our hats on it.
PK, can I tell you something? Yep. I'm going to pick on our own society. You and I know that JACC Interventions, every blue moon would put a PV trial in there. So I really don't know who's reviewing these papers. I don't know who's looking at them. I know they're not contacting me or contacting you. Yeah, well, I'm just, listen, I'm in Grand Rapids, so you have to deal with the headache of what I just said. But what you just said is a perfect example of what we need to have people that are CLI operators that are looking at these trials, because if something doesn't make sense, I don't care how good the trial is the design of a trial. I mean, that's at the end of the day. I'm respectfully, stating my discontent with the way that our society is handling some of these CLI or PV trials.
Yeah, the one other.
And I'm sorry, you're going to have to deal with the headache.
No, there's no headache. This is a very small meeting. Nobody listens to us anyway. So.
I'm sorry. Before you ask the rest of the audience, I want to show you. Can you guys focus on what? Okay, good. Thank you. So this is ultrasound guided closure of the PT that I'm showing you right now. So we pulled the sheath all the way. You can take the color off, Abby. So what Abby is doing is I'm letting the vessel breathe. I'm going to give some nitro. We're going to elongate the vessel. There is spasm there. And initially, you're going to get no flow. And then we're going to start seeing monophasic flow beyond our access point.
Actually, it was bleeding beyond it still. It's already.
So it's already the vessel is opening beyond. I'm going to remove the wire. And now I'm going to remove the sheath. And Abby's going to apply by the hockey stick probe. She's going to apply enough pressure, allowing antegrade blood flow to the plantar circulation without bleeding in the subcutaneous tissue. So that's how we close our TAMI technique patients, making sure that there is patent flow or patent hemostasis, beyond our access point. So with that, I'm going to shut up now, PK. I'll turn it back to you.
No, I think that's a beautiful demonstration. And I know that the case, I'm just going to ask the panel if they have any questions for you.
I had a comment. One of the excellent choices to use inside a stent, when you mentioned your concern about how much debulking you're doing with, passing a laser once or twice. One option is to use an Avenger device, and I think they just published their series on that, where it's image directed atherectomy, so you're seeing the stents, and you can actually do atherectomy avoiding the stent. That would be a reasonable option.
Okay. The other question, any comments on IVUS from you guys?
Yeah, I'm probably somewhere in the middle with IVUS. I certainly think it has huge value, and angiography is just two-dimensional luminology, and it's really not showing you everything that you need to know. I think it depends where you are. I think it's probably less important in iliac and large vessels where we do understand a lot. But I totally agree in tibials that I try to tell all my fellows, and I was use this phrase upstairs in the aortic session, you got to use all your senses, right?
Right.
And angiography is only one of those senses, and IVUS is another one, and extravascular ultrasound and other cues that you can get. Don't dismiss any of that. Gather that information and use it to your advantage to help your patient. I think that we all know that we have problem sizing in tibials, and I think sizing in tibials is absolutely critical. So I think Brian's
requiring
points were really
gentle.
Oh, well, Fadi,
I just had a question about the IVUS. The whole idea with the Revasc is to achieve physiologically significant flow to achieve wound healing. But I've not seen a single data which says that this much amount of space or this much amount of area stenosis improvement with IVUS correlates with wound healing. Because at the end of the day, that's what we're trying to achieve. And we're not trying to modify the plaque. Even though we claim we modify the plaque, we essentially do a controlled disruption of the plaque. And we put a scaffold and so on. So if you're not really modifying the architecture and not altering the natural course of the disease with these interventions, what exactly am I looking in the IVUS once I finish the procedure to see that, hey, I did the IVUS, and this is the end result, which should correlate with my wound healing?
I'm going to leave that to Brian.
No, that's a great question. And, so you ask the question and that there is no answer. There is no data that shows, again, that physiologic result. One thing that I have pushed Philips with very hard on is developing, so the chronal flow system gives an indirect measurement of flow. Why not try and standardize that approach and, then look at the various levels, the intensity of that chronal flow signal, and say, can you correlate that with the amount of flow that you're getting to a particular area? We also like to, in fairness, we like to combine that approach with PAT on the table. So you've got kind of two different modalities that can give you that information. But the reality is, the IVUS in its current manifestation, it's not going to do that. And I hope that we develop, and there's some technology that will push that. However, we don't have that in the space. So
that's a great answer, Asma.
Yes, so while we have Fadi here, I just want to pick your brain for 2 seconds, since you're a pioneer in this field. Tell me about your technique for perineal access and hemostasis.
So a question on perineal access and hemostasis, Fadi.
You know what? If we get hemostasis and I still have time, we'll show you how we do that with ultrasound guidance. So we typically used to obtain perineal access from a medial approach, the same way we access the PT. But over the last 2 to 3 years, we actually utilize an anterior approach because the perineal tend to kind of live between the two bones, the fibula and the tibia. And we use a long needle to access the perineal artery. Now, I will say that I always try to protect my perineal access by placing a sheath, because we get in trouble if we just work sheathless. You can get away with it, but based on the hundreds of thousands of cases that we've done, the complications that we had is when we did not have a sheath. So we will utilize an integrated approach, ultrasound guided. We use a longer needle. We never, shouldn't say never, but we would really rarely use the perineal as a TAMI technique, so we're usually using it in a CLI patient for revascularization of proximal disease. And we tend to do hemostasis with internal balloon tamponade. And one thing I've noticed is if you access the perineal artery distally below the compartments, just as an observation, never been described anywhere, the bleeding actually happens to the outside. It does not travel in the compartment, which is refreshing. I mean, it's a good thing. We're happy about it. So that's kind of our approach.
Well, thank you, Fadi. Fadi, if I think for the sake of time, we're gonna thank you. We're gonna thank your team for this incredible demonstration of these two cases on a Saturday. Fadi, and you and Jihad have been so supportive of us, and I really can't thank you enough for the inspiring discussion, and also really dealing with some of the difficult questions we have with treating these patients with CLI. So I applaud you and your team, and thank you again. Thank you again.
Great case.
Have a great day, everybody. Thank you.
Thank you, Fadi. We'll talk soon.